Shall we then move on to item 6 on the agenda? Jane, transforming care for people with learning disability and or autism.
Thank you, Chair. So this report just provides a progress update really on what we've been doing. And I just really wanted to start off by saying that although the report does contain numbers and plans, one of the things for me that's really important is actually the impact we're having on individual people's lives. And one of the things that we've done more recently is spend time with people that have actually been discharged and their families. And some of the feedback we've had around the difference it's made for individuals who've been in hospital, for example, over 20 years, that are actually now living in their own homes, supported by carers, and able to choose and do what they want on a day-to-day basis, really does bring it home to all of us that work on this programme why we're doing it. And I think that's an important context to set. So overall, we are beginning to see, I think, some progress. It is a very big and complex programme. It's not easy to do the things that we want to do, but we've seen an overall 8.5% reduction in the number of people that are inpatients. And what we've also done over the last 12, 15 months is had a real focus on identifying the people that are actually in hospital. So what that's meant is that we have discovered that there are patients that are inpatients who have been diagnosed with a learning disability while in inpatient, or they've been in a mental health bed and not previously been reported. So we've got a significant focus now on actually identifying those people who are in hospital with a learning disability and or autism alongside a behaviour that challenges, which has meant that they need to be in hospital. So if you looked at the total number of patients we thought were in hospital in March last year, we've actually seen a 30% reduction. And I think that's quite significant. And we've also seen over 190 people that have been in hospital for over 5 years discharged. And these people are often the ones with the most complex needs. So taking time to make sure that when they're discharged appropriately with the right support has been really, really important. The other area I think that's worth identifying is the progress we've made in terms of actual bed reductions. Part of the plan we've got is to reduce the overall number of beds between 35 and 50% in 3 years. And what we've started to see now are beds actually closing, and the paper describes some of those. So we've had assessment and treatment units that have been closed. We've had something like 55 beds in total that have already changed or already stopped. We've also created, almost like forerunners, I suppose, to STPs, transforming care partnerships. And the purpose of that was to bring people together so that they started to commission and work on a wider footprint alongside providers and alongside people with a learning disability. And each of those TCPs have now submitted their plans. The plans are highly ambitious. They are clearly setting out plan to deliver at the upper end of the percentage that we were looking for, and those have all been subject to quite detailed confirm and challenge sessions from the regions. And so alongside that, we've agreed that we're going to do some additional work on almost like a 4-point delivery plan. What are the things that are going to have the biggest impact? Because there's a lot of work to do and because it's complicated, one of the things that there is a risk of is that we really do, I think, spread ourselves too thinly. And it was a point that's been made by Ian in the past about, do you do something well but at depth and then spread, or do you try and do a lot of things on a shallow level? So what we're looking at doing is actually doing things well, understanding that and then spreading it. So we're identifying high impact actions. We're looking at what we've called strategic resettlement, which is place-based, population-based commissioning on a big scale, looking at what's needed for the people locally. So we commission the right services in a community setting. We're looking at extending the fast tracks, which is what we put in last year, and really concentrating time and effort where we're going to have the biggest impact on people, and also improving our data quality. So alongside that comes some additional funding, and we'll shortly be announcing the additional transformation funding that we're making available to the Transforming Care Partnerships, and also the additional capital funding that we've got available for them, and that announcement will be very, very soon. The other area I wanted to really focus on and just flag is that we've said We've talked a lot about changing what happens at Calderstone's Foundation Trust, and alongside that was a plan for Calderstones to be acquired by Merseycare. That's now happened, and it's happened within the timescale that we agreed. So Merseycare became a foundation trust, and they've now acquired Calderstones Foundation Trust, and the Calderstones name doesn't exist. It's now part of Merseycare, and we're hoping to shortly also launch the consultation on the future use of that site. So I think, in summary, I would say that we are beginning to make and have made some progress. It's a complex, difficult programme. It's not something that NHS England can do on its own. One of the benefits of this programme is that we are working in partnership with ADAS, LGA, Association of Directors of Children's Services, alongside NHS Improvement, HEE, CQC. And it really is a true partnership across all of those organisations. NHS England we take the lead, and I chair the delivery board alongside Ray James from ADAS. But I think it's important that we do recognise this is a system response. It's almost, in a bigger sense, a societal response to how we, as a society, treat and care for and support people with a learning disability to live a life that they want to live with the choices that they need and want. So I won't go into any more detail on that, other than to say we have made progress, we'll continue to make progress, and I'm very happy to take any questions.
Well, thank you, Jane. The board has taken a very strong interest in this from the beginning, so commendation to you and the team for the progress that's being made. Let me raise, yes, please, Victor.
Well done, Jane. I think it's a really clear exposition of a we've been around the circle of clear plan. Just I want to test an assumption that the change in the name regarding Calderstones is also changing function.
Not yet. We are decommissioning beds at the moment, and have done, from Calderstones, or from that site, from the Whalley site. And the consultation, which is just being finalised, will actually set out what the plans are for that site, and that's part of building the right support, and it's part of our plan to commission services around the needs of people in that part of the world. The other issue for that is that there are several people in Calderstones on that site, the Whalley site, that actually are from around the country. So there's something about repatriating people to close to where they come from.
And can you just say, as much as you can say, about what the current barriers are to making faster progress? Because you've made progress clearly, but we'd like to move faster. So I'm just wondering whether you can say anything about the barriers.
So some of the barriers are around determining what is the right service to commission in the community. The fast tracks we've had running so far have often commissioned crisis response teams, providing support 7 days a week, being able to identify the sort of 25,000 of the population that are most at risk of admission, so that the care is almost preemptive rather than crisis. So that's some of the work we've done. The other big issue, I think, it's fair to say, is that because for an individual CCG, the numbers of people that they might need to commission services for are quite small. There's a lack of expertise in terms of being able to make sure that the focus is on those individuals. So by bringing people together in the Transforming Care Partnerships, we are bringing that expertise together for a wider footprint. So it's back to the place-based type commissioning that we need to do. So that's the other one. And then another key one is that in some cases it is quite difficult to recruit the right people to be able to support care, and we have to double run for some of these services, which is why we're giving transformation funding out, so that we can actually double run. We can provide the funding to move with people when they come out of hospital into a community setting, and that can be quite complex to do in when you're doing it for individuals.
Jane, you referred there to the small group of target population in CCG. In the definition of the paper, we use the term autism, but of course clinically we've now moved towards autistic spectrum disorder, and that's really a gradation that blends into normal society. So it brings with it a danger of sort of mission creep, that you end up with an ever broader population that would fall under this remit. Can you just reassure us that we've got a clear idea of who our target population are?
Yes, I think it is a really good point. So obviously some individuals with autism also have, or an autistic spectrum disorder also have a learning disability. Others may have behaviour that challenges. So where we're concentrating on, and the definition we used in building the right support, was people with a learning disability and or autism with behaviour that challenges, and that's what. I don't like the term challenging behaviour because it feels quite negative, but the impact that might have on individuals and their families and the ability to live in a community setting is often the issue that sparks an admission, and that's what we're addressing.
Thanks, Malcolm. Genius, very encouraging, and I'm sure this is incredibly complex to manage. But I just wanted to ask, because you're taking a person-focused, individual-focused approach, and finding alternative and better placements for individuals, the decommissioning of placements, as it were, could therefore be seen to be random rather than planned. And is there a risk that we end up decommissioning a significant amount of NHS provision, and later on, actually when placements might break down or not be suitable any longer, we're reliant on private sector alternatives? So I'm asking, I suppose you're planning for individuals, but actually what would you plan for a population, and will we end up in the right place with the population plan as well as the individuals?
So I think the key answer to that is, it's in the words of Helen Bevan, it's both and. So you have to look at individuals, but part of the approach around the strategic resettlement is that we look at a bigger place-based idea. So you look at what are the needs of that particular population in terms of the numbers of people that might be at risk of admission and what type of services they might need collectively. So you have to do this on an individual basis, but if we do that, we miss the point about what the wider needs are. There are some parts of the country where the number of inpatient beds available are actually quite low, and in many cases we might need to commission more in those parts of the world. And alongside so how many do we need? We need to think through the totality of the beds, not just one form or another. And we are looking at the whole inpatient provision, not just those that are NHS provided. So it's a good point, and it is something that's part of the plan, part of the TCP plans.
Okay, so Jane, thank you very much for the paper and for the continuing good work on this. I think I just need to invite the board to note the paper, to note the review timetable you've got for the TCPs, and also the approve or just endorse the 4-point delivery plan in Appendix A.
Thank you.
So we're content to do all of those things. Thank you very much.